There are important differences between a bone infection caused by direct versus indirect inoculation. One means for contracting osteomyelitis through direct inoculation is from a contaminated wound, overexposed bone, or open fracture. Consider an employee at a construction site who sustains a serious injury to the lower leg, whereby the tissue and muscles are torn off and both the tibia and fibula bone are shattered and exposed. Osteomyelitis is almost unavoidable because of the bone exposure, in conjunction with tissue trauma and high bacterial exposure at the work site. Direct inoculation can also occur from contamination during surgery. Sources of contamination include poor skin preparation before surgery, cross-contamination by clinical professionals, or an unsanitary environment before, during, or after surgery. Following strict infection control and universal precaution guidelines can help mitigate the risk of direct inoculation from these sources. Direct inoculation can also develop from foreign objects penetrating the skin and bone. For example, a machine shop operator who sustains a penetrating arm injury is at high risk for developing osteomyelitis through direct inoculation because of the metal penetrating the skin and bone. Hardware or prosthetic implants can also contribute to the development of a direct inoculation infection. In fact, this is one of the major concerns health professionals have when patients have surgical hardware, such as plates or rods, implanted for procedures such as spinal fusion or total joint replacement of the shoulders, hips, or knees. During surgery, the surgical site and hardware are flushed copiously with antibiotic solution. But even in the most sterile environments during surgery, the smallest amount of bacteria may multiply rapidly on the metal, which then becomes the focal site of the infection.